Listen, thank you all for coming out here today on a Saturday. It is great to see so many of you in the audience, and well done to Rachel and Miriam. It's a tough act to follow. So as Owen said, I'm a consultant neurologist in St. James's Hospital, and really through my training as a registrar, I gained an interest in FND, which actually probably wouldn't have been called FND at the time when I was a trainee. But I actually noticed that many patients were not being treated appropriately, and I sort of gained this kind of interest into kind of why that was happening and what was going on. So that's sort of where my interest came. So sorry, I'm trying to fix my notes and also not make everything go haywire. So as Owen said, I'm going to give you an overview of functional neurological disorder. And what I'm going to talk about is what is functional neurological disorder, or FND. I want to give a very brief history on how FND has been understood over time. I'm going to talk about why and how FND happens, how neurologists diagnose and treat FND, and then the future of services for Ireland, which I'm sure you're all very keen to hear about. So what is FND? Well, FND is a brain network disorder of voluntary motor and or sensory function. In neuroscience, the term voluntary simply refers to movements that are normally under our conscious control. So for example, I voluntarily choose to pick up a cup versus I automatically withdraw my hand because the cup is too hot. And FND happens because the voluntary systems in our nervous system are disrupted. It can look like, it presents with a wide range of neurological symptoms. So the most common symptoms we tend to see are weakness, movement disorders like tremor, sometimes what we call functional seizures. But any neurological symptom you can think of, I can guarantee you at some point has presented in a functional manner, but they tend to be the most common ones we see. It can look like other neurological conditions, and particularly to professionals or people who don't have a neurology background, it can be confused for other conditions like stroke or epilepsy or Parkinson's disease. But the difference is that the basic wiring of the nervous system in somebody with FND is intact, and there's a problem in how their nervous system functions, and that impacts how your brain and body send and receive signals to each other. We know the stressful life events are risk factors for FND, but they're not always present, and I mention that here because for a long time it was thought that the symptoms were caused only by stress and trauma, but we know that that's not true. And symptoms can improve or recover, but particularly if it's diagnosed and treated early. It doesn't mean if you have FND for a long time that things can't improve or that you can't recover. It can be a little bit more difficult, and as Miriam alluded to, people can make improvements, they don't always get better. I think sometimes there is a misconception because there's no damage in the nervous system, because it's FND it should just get better, and unfortunately we know that that's not true for everybody. I'm sure many of you in this room are aware of the computer analogy that's sometimes used to help patients understand FND. If you think about your brain like a computer, there's hardware and software. The hardware is fine, but there's a glitch in the software of the brain in somebody who has FND. So the messages between the brain and body are scrambled. We estimate that there's maybe 9,000 people in Ireland with FND. We don't have reliable Irish data, and we do need to do more research into that. Some work out of Scotland last year gave a figure of about 9,000 people in Scotland with FND. It's a similar population size. I don't think it's totally unreasonable to extrapolate from that, and it's possibly even an underestimate. We do need more work to really determine the number, but we think that's probably pretty accurate. So a similar number to those who have MS in this country, and yet MS services are much better established than FND. We know that FND is more common in women. Women are 3 times more likely to develop FND than men. It typically occurs in a working age population between the ages of 20 and 40, but it can happen to anybody at any age. I met an 80-year-old woman in clinic this week who's developed a functional tremor, and we're increasingly recognising it in teenagers. We know from the literature that it's the second most common reason to see a neurologist as a new referral in outpatients, and it's consistently in the top 5 neurological conditions that are diagnosed by neurologists. So I'm just going to give you a little background because I think the background is important. The way that FND was viewed in the past has really shaped the lack of services and the support we see today, and I think if you understand that, it helps you understand why we are where we are. So this is Charcot. He was a French neurologist and one of the first people to study what was then called hysteria. And although hysteria is obviously a derogatory term today, actually, you might be surprised to hear that in the 19th century, things probably weren't actually that bad. And Charcot and his colleagues probably had a much more compassionate and understanding view of these symptoms than many people who've come after them. And they recognised that the symptoms were genuine, even if they weren't explained by a structural disease. They treated patients with a neurological framework. They didn't dismiss them. And in many ways, actually, the work of Charcot has probably laid the groundwork for what we understand in a modern way of FND today. Freud came along then after Charcot. He briefly studied under Charcot in Paris, and he took this idea of hysteria in a very different direction. And he coined this term conversion disorder, which basically said that physical symptoms were a symbolic expression of a hidden emotional distress from a repressed trauma. So basically, an individual was not able to confront this emotional distress, and it converted itself into physical symptoms. And we know that a history of childhood and adulthood adversity is a risk factor for some people, and it does increase your risk of developing FND in later life. And I think if those aspects are identified for an individual with FND, it's important if they're ready and they wish to address them, to acknowledge them and address them. But we know that it is just a risk factor, it is not the cause. And many people with FND have no history of trauma or stress. And many people have unfortunately experienced trauma and they don't go on to develop FND. So it's a little bit more nuanced than how Freud was thinking about it. So don't get too overwhelmed by these criteria. I'm going to take you through the important points. But these were the DSM-4 criteria for conversion disorder. And the DSM is essentially just this large manual that healthcare professionals use to help them code and define both mental health and some other brain-related disorders. And the criteria for conversion disorder, or at least variants of it, was around from probably the early to mid 50s until 2013. Okay, so this criteria was used to diagnose your symptoms for about 6 decades. Okay, so you can see here psychological factors are judged to be associated with the symptom deficit. So for decades, if we wanted to diagnose your symptoms, we had to identify, according to the criteria, a psychological factor in association with your symptoms. This one's a bit weird, but we had to prove that you weren't faking it. The symptom or deficit is not intentionally produced or feigned. So this was part of the criteria, and I think it has fed into, unfortunately, the attitudes that have come about in relation to FND. And the symptom or deficit cannot, after appropriate investigation, be fully explained. So it was also a diagnosis of exclusion. The doctors did all their tests, they didn't know what was wrong, so it must be this. And the problem with these 3 points was that it shifted the understanding of your symptoms very much away from neurology, firmly into psychiatry. Psychiatrists also didn't really know what to do with you, and unfortunately nobody did anything. And as a result of these, and particularly the psychological factors proving that people weren't feigning their symptoms, that meant that patients were often frequently misunderstood, dismissed, and specialist medical services just largely disappeared. And it's one of the reasons today why we don't have services, and why there's, yes, there's services internationally. They're probably not on a par with services for other medical conditions. And I know many of you have had very poor experiences within the health system. There is absolutely no excuse for the behaviour that you have encountered, but this might at least be some way in helping you understand why that has happened, and that these factors really were hugely influential and dominated medical thinking for decades. And then in 2013, the DSM-5 was published, and 2013, it's not that long ago. But that's when things began to change. And the big factor in 2013, from a lot of work with Jon Stone and Alan Carson and colleagues, they removed the need to identify the psychological factor, and they removed the issue around malingering and feigning. So they are now notes in the DSM-5. So we acknowledge that a relevant stressor is often present, but not a requirement to establish the diagnosis for patients, and malingering or feigned symptoms are not considered functional. However, the absence of feigning or malingering is not a requirement to establish the diagnosis. And then just the important point within the criteria, which I'll show you some videos to demonstrate this in a little while, but clinical findings provide evidence of incompatibility between the symptom and recognised neurological or medical disorder. So that reflects that FND is now a diagnosis of inclusion. So I meet somebody, I take their history and I examine them, and I'm able to make the diagnosis based on my clinical findings. That's similar in Parkinson's disease. I don't do any special tests. I meet somebody, I take their history, I examine them, I'm able to make the diagnosis. It's a diagnosis of inclusion based on what I'm finding. So why does FND happen? We largely divide it into predisposing factors or risk factors, precipitating factors or triggers, and then there's perpetuating factors that can sometimes keep the symptoms going. So when we look at predisposing factors, having another neurological or medical condition can be a risk factor for developing FND if your brain is vulnerable to develop it. Having another functional disorder, so irritable bowel syndrome, chronic pain syndromes, they're not FND, but they are functional disorders in their own right. Psychological factors are important for some. I alluded to a history of childhood or adulthood adversity, having a history of anxiety, depression, PTSD. They can be relevant for some people. There's likely genetic risk factors. There's been a little bit of literature looking at, and by that I don't mean that it's genetic and you can pass it on, through your family, but there is probably something in somebody's genetic makeup that may influence how they respond to certain situations. And we do have a little bit of evidence that in the literature, and there's more work into that to try and see if we can understand what might be different about somebody who's vulnerable to develop FND. And occasionally you don't have any risk factors. It's tough to find any vulnerability in somebody. And then triggering factors or precipitating factors, these are just examples. Please don't look at this list and think that if a triggering factor for you isn't on this, that it means something. These are just examples. And they can be pathophysiological or psychological. So, and often they're pathophysiological. I will often meet people who have had another medical illness or they've had an injury and they've been vulnerable and it's precipitated their functional symptoms. They can have a drug side effect. They can have a syncope or a simple faint, or they have an actual seizure, which then their brain misinterprets and they go on to develop functional seizures afterwards. That doesn't mean that everybody with functional seizures has had an epilepsy seizure, but it is a factor for some. And it's not uncommon that you often see after mild brain injuries that people develop or can develop debilitating functional cognitive symptoms. And then some psychological triggers that can trigger FND for some people are a panic attack, dissociation, the onset of anxiety, depression, PTSD. And then things that keep it going or perpetuating factors are diagnostic uncertainty. So if you're meeting lots of medical professionals and nobody really knows what's wrong, that's going to feed into the process and not help you get better. A misdiagnosis, patients can be given a diagnosis of another neurological condition and FND is missed. One issue is I think that neurologists worry that they'll miss something else. And I always say to them, well, you should be very worried actually about missing FND because there's an opportunity to help people. So the converse is also true. Poor communication, if somebody hasn't communicated the diagnosis well, if they told you that you should just get better, or you've felt dismissed, that's not going to help your symptoms. A lack of treatment, so you can get the diagnosis, but if there's not a multidisciplinary team in place to help you, you will struggle to make progress. Unnecessary investigations and management. Some patients come and see me and they worry that we're missing something else. There's always going to be another investigation we can do. It's important to know when you actually say no and stop investigations and you're confident in the diagnosis. And then there can be obstacles to recovery. If somebody has another neurological or medical condition that's also very difficult for them to manage, and that's a predisposing and triggering factor for their FND, that can be an obstacle to their recovery. Fatigue and pain are common comorbid symptoms that we see in FND. We don't consider chronic pain and chronic fatigue FND symptoms, but when fatigue and pain are present, they can be obstacles to somebody's recovery of their functional symptoms. And occasionally people have unhelpful beliefs about their illness. They believe that we're missing something else or that the drug side effect has caused their symptoms and not triggered it. And you can try and educate people and you can try your best and patients can try their best, but there can sometimes be obstacles to recovery. And as Miriam pointed out, it's then about what can you do to at least help somebody live a life that has some meaning and have a quality of life. So that's why FND happens. Now, how does it happen? So we know that various networks are involved in FND, and these networks map onto what we call constructs or concepts in the brain. And these include a sense of control or agency, attention, prediction, motion and salience, and body awareness. And I'm just going to show you a table that I'm going to explain what each one of those concepts normally does and then what happens in FND. So if you think about attention, our attention helps us focus on the right things. And what happens in FND is that the brain focuses too much sometimes on body sensations or symptoms. Emotion and salience decides what's important or threatening normally, and in FND the brain's alarm system stays switched on when it's not needed. Sometimes I say to people it's a little bit like every time you try and make toast in the kitchen, the fire alarm goes off. That's sort of what's happening in your nervous system. With a sense of control or agency, so that normally that gives you the sensation that I'm moving this. If I raise my hand, I have an idea that I've done that and I've raised my arm. That signal is disrupted in FND, and so movements will often feel involuntary, and that's what you hear in clinic. Patients will say, I don't have any control over this. It feels like, it feels like my arm is moving by itself. Body awareness or interoception, so that is your awareness of internal bodily sensations. Normally it tracks your heartbeat, breathing and sensations, and in FND those internal signals are often misread and amplified. And then prediction is important. So our brains are never just reacting in the moment, our brains are constantly predicting, and they expect what's going to happen next. And strong expectations or predictions can go wrong in FND, and then they override your normal movement or sensation. So how do we treat FND? Well, you deserve a clear and supportive communication of the diagnosis. I know that does not always happen, or it hasn't happened for the majority of you, but that is important. If you don't get a clear and supportive diagnosis, you don't understand what's going on, it can be very hard then to move forward in terms of therapy and treatment. So that's really important. Jon Stone always tells healthcare professionals, just stop being weird when you're diagnosing patients. I think for some reason, and I think if you think back on those criteria, those really unhelpful criteria for 6 decades, like that's fed into people's attitudes. I think they feel a bit awkward, they don't really know what to say. That's not an excuse, but I think people struggle also in terms of how to communicate, and it's our role through FND Ireland and as healthcare professionals to help other professionals understand how they should be supporting you and communicating the diagnosis. It's then important, once a person has the diagnosis and understands their diagnosis and believes that diagnosis to be the correct diagnosis, that you then triage them and coordinate their care within a multidisciplinary team. Okay. At the moment, yes, there's a small team coming to join me, but at the moment it has just been me, occasionally seeing patients with FND, and it's very difficult to do my job all by myself. There's a skill set that the physio, OT, psychologists, psychiatrists, speech and language therapists bring to a team that I don't have. So it's really important to work as a team with FND. And consistent messaging is important. I have diagnosed people with FND and then their GP has dismissed that diagnosis or hasn't agreed with me. So it's really important as well that we feed out into the community and make sure that everybody understands what's going on and that a person is getting consistent messaging about what's happening for them. It's important to recognise comorbid conditions and manage them appropriately. If somebody has another neurological medical condition or they have a mental health disorder, it's really important that you recognise that and also manage that and not just focus on the FND. Recognise if there are barriers to recovery, and as I said, everybody can try their best, but it is also important to know when treatment might not be right for somebody at that particular time, and you can be respectful to an individual and have an open door policy that when they're ready they can come back and explore treatment again. And then I think follow-up is really important. It supports recovery, it maintains trust and validation, it allows you to review any new issues, prevent unnecessary hospital visits. So I do think follow-up is important. I don't think that anybody should be getting the diagnosis and then just discharged from clinic. So neurology versus psychiatry, the big divide between neurology and psychiatry, and who's really responsible for looking after FND. FND is really a mind-body process. I hope I've helped you understand that it's a mind-body process, and it's those processes that go wrong in FND. If you look at attention and prediction, yes, they're brain functions, but they are constructs and concepts within our minds. And all illnesses, not just FND, sit somewhere on a mind-body spectrum. But I think FND shows that boundary much clearer than others. And the symptoms arise because there's an integrated motor, sensory, emotion, cognitive network dysfunction in the nervous system and in the mind. Okay? The mind and body, the mind and brain cannot be separated from each other. And so people talk about FND falling between the gaps of neurology and psychiatry, and I don't think it has fallen into a gap. I actually think that FND is a bridge that should actually be bringing the two specialties together. And I think if we want to understand FND, we want to make FND care optimal, I think it demands that we actually work together as specialties and not stand on opposite sides. I have a role as a neurologist in making the diagnosis based on clinical signs, ensuring that we don't miss anything else, that we don't over-investigate things. It's my responsibility to give a clear and confident explanation of the symptoms, make sure that you understand it's real, common and reversible. But psychiatrists can also be really helpful in developing what we call a formulation as to why these symptoms might have developed for somebody. They have a skill set that enables them to explore symptom patterns and how they fit into somebody's life. Your story might not have anxiety, depression or any sort of trauma in it, but our life experiences, including mine, including anybody else in this audience who does not have FND, they shape how our brains predict, process and respond to the world, even when nothing dramatic has happened. Our coping styles are learned at a very young age, and these all shape how our bodily signals are processed. So everyday stressors can overload and disrupt those brain network functioning in somebody, and there are everyday stressors that we all experience. So in terms of the future of services in Ireland, so we now have a working group established under the neurology programme, under the governance of the HSE, to develop an optimum pathway for FND services. Be mindful that we will develop an optimum pathway. An optimum pathway does not mean that all the services we want will naturally come along with it. There will also have to be business cases and a fight for those resources, but we are at least designing what we think an optimum pathway should look like. Education and awareness for healthcare professionals is already happening. Lots has happened. I held an update meeting for healthcare professionals in 2022. I'm continually delivering lectures, some of which are recurring to medical students, postgrads, GPs, neurologists, psychiatrists, psychologists, hospital physicians. Owen is doing plenty of work as well, helping to educate people. We have another study day planned for early next year, so it is all happening in the background. You'll see in this slide, this was a paper published last year, and Ireland is in red. We were the only country in Western Europe without any service for FND, and actually if that paper was published this year, it would probably actually have to be changed, and Ireland would be in blue, thankfully. I think it's important that we incorporate primary care and community services into the development of services for FND. There are, lots of patients who can be managed within the community. I think all neurology centres must manage FND and do it well. Specialist centres, they are important. I have to manage your expectations and tell you that it will take time for specialist centres to expand. The clinic in St James's itself is very small. I am one single neurologist. I have a clinical commitment to other elements of neurology and not just FND. And there is a physio, occupational therapist and psychologist coming to join me. And I appreciate the frustration. There is obviously an inequity where initially patients within St James's catchment may get to see me and others don't. But I think if St James's immediately opens the gates to a national referral service, it will shut down almost immediately. The waiting list will become too long. And that's not me being anxious, that is from international experience. This has happened to other people in the UK who have tried to do that, and people who are much more experienced than me, and I would be very much guided by what they have done before and what has worked for them. There will be an opportunity at some stage for sure to offer second opinions. When that will happen is still to be determined. The team haven't joined me yet, and I think the team needs to start, and then we need to see what happens. I do think the development of the service in St James's will act as an excellent outreach service to other to other neurology centres, and I think it will give other centres and other therapists in those places confidence in how to communicate the diagnosis and manage the more mild to moderate cases. And that might seem unrealistic given your experiences in the past, but I do think it is a place to start. And it might seem like nothing's really happening and it's all very slow, but I think you have to acknowledge, like, the work that FND Ireland and particularly Eamon has done in the last 12 to 18 months has been remarkable. I have never seen a movement like this really in anything else ever. So I would just ask you. So I just ask you to stay positive and know that everybody in this room here today is actually working on your behalf and trying to advocate for better care. So the take-home messages are that FND is real, it's common, and it is treatable or at least manageable. It's a diagnosis of inclusion. Several brain networks are involved. A multidisciplinary approach to management is essential. Psychology input doesn't make FND any less real. Psychiatrists have a skill set that can be valuable, and progress is underway. Thank you.